Good afternoon, everybody. Now, I'll be just going through some of the difficult scenarios we come across during cesarean sections and how we could possibly tackle them. I'm sure you all could contribute much more than I would in this. Now, when you talk about a cesarean section, we start from the skin, okay? Now, when is it that we go in for a vertical incision? Now, we all know that we often go by the typical phalansteal incision, which is nothing but 2 to 3 centimeters from the pubic symphysis. It's a curvilinear incision within the hairline and in the Langhans lines. And you go transversely for the skin, the rectus the rectus sheath, and we separate the rectus muscle from the rectus sheath and we put a vertical peritoneum. Now that's what we normally do for all cesareans. But in the event of us having, or we anticipate a problem, then the best thing would be to go by a vertical skin incision, okay? And preferably a subumbilical midline incision. Now, so one is when you anticipate problems. Next, when we are contemplating a classical cesarean, for some reason you think that this patient might require a classical cesarean, for heaven's sake, don't go by the phalansteal. Yes, you can do the muscle cutting, but it's not as good as the vertical. And whenever there's an intra-abdominal path and when you feel that you will have to tackle that also, then probably the vertical skin incision is important. So always I will say plan your surgery. Every surgery should be planned, and the most important is the skin incision, because haven't you seen that when we have a problem and when you call the surgeon, he'll say, oh gosh, you've gone with the phalansteal, and they curse you 100 times for it. So always plan your skin incision. It's very important. Now, do you excise a scar? Always preferable to excise a scar. Okay, the scar is just a skin tissue that's being cut. The rectus muscle cutting if required. Now, we normally don't cut the rectus muscle. Even in the phalansteal, we don't cut it. But if at all you want to cut it, you need cut only the medial 2/3, because it is always lateral to the belly of the muscle is your inferior epigastric. So if by any chance inadvertently it extends a little beyond that, then you may cut into the inferior epigastric, and heaven forbid you cut into it, please remember, get it and ligate it preferably, because most of the time it might recede. Or if you think that it might extend, you can ligate and then cut through that, so that, otherwise many of the times it might recede up, and that is one of the commonest causes for abdominal wall hematomas post-op. So if you have to cut it with some difficulty in delivery of the head, cut only the medial 2/3. It's more than enough. Now, how do you open the peritoneum? It is always the upper third, especially in a prolonged labor or a scarred abdomen. At least in these two conditions, you should go open the peritoneum only in its upper third. And if it's a scarred peritoneum, a scarred abdomen, you'll have to sweep your fingers after the nick. But I'll say before you nick, you have to tent it. And when you tent it, you feel whether there's any structure inside. And the structures we look out for are the bladder, sometimes the omentum, and very rarely the gut. So feel that there is nothing. Many of the times you may not be able to enter the abdomen at one go. You will have to cut, again pick up, again pick up, again cut, again pick up. You may have to do it several times, especially in a scarred abdomen. Take your time. That is when you are safe. Don't ever think that you have to open the peritoneum at one go. And after you have made the first nick, and if it's a scarred abdomen, put your finger inside and just sweep, so that you know there are no other structures adherent before you extend your incision up and down. Now the bladder guide, I'll say this is very important. We always look, and for the transparency, look inside the abdominal wall. Through that you look up, then you will see the transparency of the bladder. Okay? And that is your guide, and preferable to stop short 1 centimeter from the dome of the bladder. Okay? And yes, the urachus is often our guide to tell us where we are. Now, many of the times you have a lot of omental adhesions when you enter in for a previous cesarean. Now, don't go to remove all the omental adhesions then. You will have to remove it, let me tell you that. But that is at the end of surgery. But when you go in at the first time, just release enough only to get in, because it will take a lot of time, and you must release it from its origin from the peritoneum. Okay, don't allow it to dangle there, dangle here, then it causes more post-op adhesions. The uterine incision. Now this is very important in an obstructed labor or a very prolonged labor. It's preferable to put your incision high up on the uterus. Okay. If not, if you put low down, then you might enter into the vagina and you might be doing a vaginal cesarean. In fact, some time back I was called for a cesarean from a hospital, And she said, I don't know, ma'am, where the anatomy is. And when I looked, she had entered through the vagina and that had gone laterally extending all around the circumference of the vagina. So please remember, in a prolonged labor, an obstructed labor, let your incision be high. And when she is not in labor, please put your incision low down. Because if you put it high, then you might sit in a person who is not in labor, you might be sitting in the upper segment. Do you understand? A preterm, yes, you may require low segment vertical. Now, because all of us are so conscious about our babes, the preterm babes, the neonates, the neonatology sitting on our heads, and we are rescuing small babies, yes, sometimes you may have to put a vertical lower segment. And most important is not that. We put a vertical lower segment because the space in the lower segment is only so much. You can't take out the baby through such a small incision. So you may have to put a vertical, okay? But most important is if there is an extension to the upper segment, it should be noted in your notes. It should be written in your notes for posterity so that the subsequent obstetrician is going to tackle the case, will not give her a VBAC and will go for a repeat cesarean the next time. So whenever you enter into the upper zone, you must remember to make a note in your notes that entered the upper the contractile segment. Now, if there's a fibroid over your incision, okay, if there is a fibroid over your incision, the most important thing is, please see that you enucleate the fibroid. Don't keep on cutting through the fibroid. You will reach nowhere. You understand? So either you go cut above the fibroid, or you cut below the fibroid, or you enucleate the fibroid and then enter to get the baby. Don't go through the fibroid. You'll be going layer through the fibroid layers. Okay, remember that. So enucleate the fibroid and put your incision. That is why I said, don't be in a hurry. I always see all of you are in such a hurry to do surgery. It takes a lot of thinking. I told you every incision should be a planned incision. There is not, before you, when you see a fibroid, how is it going to be? Am I going to have difficulty in the baby? Is the head above the fibroid or is it come down? Everything should be planned before you decide whether it's going to be the incision above the fibroid or below the fibroid, or whether you're going to enucleate the fibroid and then put your incision on the uterus, okay? Now, bladder adhesions. Now, before this, I'd like to tell you one more thing. In the event of your incision being inadequate, right? If at all you want, we put a curvilinear on the lower segment, right? If you want to, you take it up a little bit so that becomes a J-shaped incision. And even if this incision is not enough, you go this way, so it becomes a U-shaped incision. See that you always, you understand what I mean? So that your extension is like this. And heaven forbid, if you have to do that, you will have to make a note again in the notes. So also, if you are not, there are situations in which we have had to do an inverted T also. Inverted T, try not to do it, because it is a very bad scar. And if at all you happen to do that, please again make a note in your notes, okay? Now, bladder adhesions, release by sharp dissection. You know what I mean by sharp? It's always better to release the bladder before the baby is out, because at that time the lower segment is stretched out. So you'll be able to delineate the margins of the bladder. So find out first of all where the upper margin is. That is important. And then start your dissection. Sometimes it may be pulled up way up. Sometimes it may be pulled up in a crooked form. So find out where the upper margin is and then start your dissection slightly above that, and then dissect, push, dissect, push, dissect, push. Go slowly, step by step, till the entire bladder is away from your incision. Okay? So as I told you, preferable to deliver the baby before you, after you have completely dissected the bladder down. But if by any chance you find that you cannot dissect the bladder, put your incision above the level of the bladder adhesion. So simple. Do you understand? The other day I heard Professor Henry Murray say that he has always put all his incisions without dissecting the bladder above the level of the bladder. And he says he has had no problems. Now we find that we have to push the bladder down to get a good lower segment, and then we put our incision there. So if you find that you can't push the bladder, you just put your incision above that. Don't try to do anything heroic and land up with a bladder injury, okay? Now a transverse line. Now, as I told you some time back, again planning. I don't know, I always plan a lot, okay? I read the chart first. I try to understand where I image every baby in my mind. Is the baby's head going to be this side, the limbs this side, the back up? So always try to, so that you know where to go for the legs. Otherwise, like what you all were talking in the morning, you'll go and pull a hand out. But if you have mentally mapped out your baby, you know where the head is, where the back is, where the limbs are. So you know you'll have to go like this and get the limbs. And you can't remove the limbs like this. You've got to maintain and you'll have to bring it down like that. Do you understand? So always map out your baby, and if by any chance it's a transverse lie, you can actually do the version before the uterine incision is put. You've got the uterus, you've opened the abdomen, the uterus is in front of you, you feel where the head is, where the back is, and then do the version and get it a longitudinal lie and then take the baby out. So whether it is a breech or a cephalic, it doesn't matter, but try to make it a longitudinal lie. Now the uterine incision, cutting or tearing, it's individual preference, but I can tell you tearing is easy on a virgin uterus, the first time section. But when she has already had 1 or 2 scars, then you will have to probably cut through. I always cut. And the incision, why that incision is so important, because you will have to have 2 or probably 3 areas where the incision should be adequate. One is the uterine wound. The uterine wound should be adequate, because we normally deliver every baby flexed, okay? Every baby should be taken out flexed. But sometimes in a deeply impacted head, etc., when the head comes out extended, it takes a larger diameter, okay? So you will have to probably, image as to how big your incision has got to be, and then you've got to do it. A scarred uterus, probably better to give a little bigger incision on the uterus rather than have a smaller incision. And a scarred uterus, preferable rather than tearing, it may be better to cut. So you know how much to cut. You can cut more on this side, less on this side, depending on, so that you have centralized your incision between and in the lower segment, okay? After entering, the first thing that you do is stabilize the fetal lie. Make sure that the baby's lie should be stabilized, then only rupture the membranes. That's very important. If you go around incising and then you rupture the membranes also, then you may find it's a different lie and you'll have to tackle the baby that way. So you stabilize the baby's lie, rupture the membranes, position the head well below the presenting part, and a cephalic presentation, flex it and deliver. So take your time, go behind and slowly lever the head out. Don't suddenly, when you pull it out like that, suddenly is when you tear there are a lot of tears. And at that time, you can have a fundal pressure. But remember, in our hospital, as soon as we could deliver the baby, all of them are sitting on the fundus. Don't do that. See that your baby has come to the incision. Okay, take the baby up to the incision and only then allow them to give the fundal pressure. Otherwise, it will become a transverse lie. You got what I'm saying? So it's better that, it's a floating head. You slowly bring it to the level of your incision. And at that point, you can have a gentle fundal pressure and then you can take the baby out. Placenta previa, when if you have got a lot of vessels, you can suture the vessels, do the pinning sutures before the uterine incision has been put. Create a window by separating the uterus from the placenta to expose the membranes, like I told you some time back. If cutting through the placenta, be very quick as there's bleeding and the fetus is losing blood. So if you cut through the placenta, there are sometimes situations where you'll have to cut through, then quickly deliver the baby, because otherwise the baby will become pale. Alternatively, a classical section, of course, you all know, sometimes when it is a transverse lie and when the back is inferior, when you put your incision, there's nothing for you to pull on. You understand? The back is inferior, the placenta is down, and all your limb buds are on top. So then probably in such a situation, you may even have to do a classical section. So that's what I told you about planning your incisions. A high floating head, yes, you can deliver as a breech. Even then, see that before the liquor is washed out, turn the baby as a breech and take it out, okay? And as Nuzhat was saying this morning, whatever comes to your first, one limb, once you get one lower limb, you catch the feet and you deliver it out, the next limb automatically comes out. So you get that and you can deliver it out. Or you can use the forceps, or we can use the vacuum. When you use the forceps, I can give you just 2 tips. We always use it for a floating head. And we always know that the back leads to the occiput. That's our principle always. The back leads to the occiput. So you find out the back of the baby and that will lead to the occiput. So position it in such a way that you apply your forceps biparietal. You got it? Either you can keep it transverse and then you can apply it biparietal, or you can keep it this way and you can apply it, but easier to keep it transverse also, and you can apply, first put the lower blade, the left blade is the lower blade, and then that is also another important thing, okay? So these are the few tips. If you have not not been using the forceps, I'll tell you, we all learned it from Dr. Piley. It's a very useful thing, and now today we can't do without a forceps for a floating head. So you come to a situation like that. Well, those, I've not used the vacuum, but those who are used to the vacuum, yes, go ahead and use it. So as I told you all, locate the head. The posterior blade is the first blade is the lower blade. That is the posterior blade, and then you apply that. Now when you've got a deeply impacted head, you can ask them to deepen the anesthesia, okay, so that the uterus is not hugging the baby. So they'll give a relaxant, that helps. Give a steep head low, even that helps, okay. Now upward pressure, now supposing you've got an assistant to push up the shoulders, this is the assistant who's pushing up the shoulders per abdomen. Your assistant who's standing next to you, she can push up the anterior shoulder up, and then you can go below the presenting part. Do you understand? That is one method. Or else there is another assistant who's pushing from below. Now this again is very important, that the one who's pushing from below should push only enough to give the baby in your hands. If you push too much, it becomes a floating head. Then from a deeply impacted head, you're struggling with a floating head. So tell them slowly, slowly, and then once you get the grip, let the person take their hands off. And then you lever it out, bring it to the incision, and then the fundal pressure, and then the babe comes out. You understand? Now, Patwardhan's menu, we don't do it, but we have once or twice, accidentally we have had to do it. We're not as a routine, we have done it. Now when you say the Patwardhan's menu, this is again for a deeply impacted head. What you do is you remove one shoulder. Then you remove the opposite shoulder. Then, you pull out the baby's trunk. Then you go to one lower limb, and then you go to the opposite lower limb. Then the last to come out is the head. That is the principle of Patwardhan. The deeply impacted head comes out last. Okay? When you go to the modified Patwardhan, he takes out one limb on one side, then he goes to the same side leg, he goes to the opposite leg, and then he goes to the opposite limb. You understand? Then of course the head comes out last. So this is for a deeply impacted head. Sometimes it does happen, you take the arm out, then you'll have to do that. Now placental delivery, preferable to wait for spontaneous expulsion. I think you can take a good breath at that time. Don't be in such a hurry and do a manual removal for all your cases. There is increased incidence of retention of cotyledons and even increased incidence of infection. So manual removal is associated with more bleeding also. Now always check the perimeter of the incision. Please remember, if there is an arterial bleed, it must be caught in a separate stitch. It cannot be included in your running stitch. Do you understand? See, maybe a slight venous bleed, it may not matter, but when you've got a spurter, please take individual sutures for that. That is very, very important. And we always start from, now supposing I'm standing this side and my assistant on the opposite side, we take an incision and we secure this corner first. So this corner is secured, and then we stop. After one or two stitches, we stop there, and then we go to the opposite side, and then we start our suturing from that end. So both the corners are secure, and you're very sure that you have not missed out on the bleeder at that corner. Now exteriorizing. We don't normally exteriorize. Exteriorizing means nothing but delivering the baby uterus out of the abdomen. Please remember, when you take it out, you must also push it back, right? Many of the times we are struggling because we can't. And when you have to push it back, you go through a conva, one end of it, that's a conva should go in first, and that's how it goes in. So we normally do not exteriorize the uterus, but there are two situations which you must exteriorize, and one is when there's an extension of tears. You must. And second is when you feel that there is something wrong. When anything is wrong, take the uterus out. Remember this as a principle always. Take the uterus out and say, you don't know, something has happened. I don't think this is normal. I'm not able to find out the anatomy. I don't know how far my incision has gone posteriorly this side. Whatever be it, that is a situation you must, if you're not taking it out otherwise, you must take it out when you've got extension of tears and when you've got when you do not know what's wrong. They say that when you take the uterus out, you're able to identify the atony earlier, you're able to identify the adnexal pathology better, okay, and so those are all the things which they say are the plus points. But the negative points, they say that the pain is more, the postoperative infection also, I do not know why, but that's what has been claimed. Now, if you have got a tear, visualize and take interrupted sutures up to the incision area. You know what I mean? You've got an incision like this and you've got a tear like that. Take that as a separate thing and come as far as the incision and then stop. You understand? If you've got another tear, come from there, from the apex of the tear, you come, maybe retrobladder, retrovesicle, you start from there, take interrupted sutures preferably, because then you don't shorten the thing and then you come as far as the incision. And then you close the incision. If at all you have to dilate, the patient is not in labor, do not go right down into the vagina to dilate. You need just dilate the internal os in a person who's, and you do not have to dilate if she's in a laboring woman. But if at all you have to do it in a non-laboring person, go only as far as internal os, don't enter the vagina. Because once you enter, the finger enters the vagina, then you have entered a contaminated area, okay? Single layer closure, if the lower segment is thin, it is good to strengthen it by one more layer. I'll tell you one very simple thing. Now studies have shown that if she is to have another one more kid, it's preferable to do 2-layer closure. So now in our hospital, we have made it a routine. All primaries get a 2-layer closure. And if we're going to sterilize, we do a single layer and we close. So, and then another recent time when you should do a double layer closure is when the lower segment is very thick. Then maybe again you will have to put a double layer. So if she's going to have another pregnancy, good to put a 2-layer. And if the lower segment is very thick, good put a 2-layer. Otherwise you're justified. After the Caesar trial, they've said single layer is fine. Unequal upper and lower flaps of the incision, suture edge to edge. Please remember, try to find out the edge of the, there is something different, the decidua is different from the edge of the suture line, the scar. Identify the edge. You find out the perimeter, find out the edge and suture it edge to edge. Sometimes you find a thick upper part and the lower part which is very thin. Then you take one stitch and another stitch and then pull. Take a one stitch, another stitch and then pull. Then you don't cut through. The lower leaf will not cut through. Tackling of a broad ligament hematoma. When you've got a broad ligament hematoma, again take it out. Again, I told you, if any problem, take the uterus out. You open the leaves of the broad ligament. Always the bleeder will be from the uterine artery. There's no other vessel beyond that, right? So always, even if you've got a huge broad ligament hematoma, even as far as the splenic flexure, the bleeder will be below the pelvic brim. Please remember that as a clinical point. So don't go searching for it as far as that. Your bleeder is somewhere there. Peritoneal closure, yeah, we do not close. We do not close both, okay? I'm sorry, we do not close the visceral peritoneum, but we close the parietal. If there's a suspicion of a bladder injury, even if you're in doubt, please instill methadone blue through the urethra from below and check. And if you find it, please do close it in 2 layers or 3 layers, depending on how thick your bladder tissue is, and put in an indwelling catheter for 7 to 10 days. So even if you've got a doubt, please instill it. If it's a ureteric injury, which is very rare, it happens only when you're blindly suturing. I told you some time back when you got an extension of tears, and if you don't deliver the uterus out of the abdomen, then you might injure the ureter by blind suturing of these tears, keeping it inside the abdomen. So whenever I told you tears, take the uterus out. So therefore you prevent it by suturing extensions only after exteriorizing the uterus, thereby the ureters drop down. When you take the uterus up, the ureters drop down. When you suture them inside, the ureters are very close, you might injure it. Otherwise, normally we have no ureteric injury with the cesarean. Bowel injury, only serosal tears we suture. If there's a mucosal involvement, we get the surgeon to help us. Classical section, yes, lower segment containing fibroids, lower segment with dense adhesions, making entry difficult, placenta previa of the transverse lie back down, cancer cervix, placenta accreta. Prophylactic antibiotics, yes, it is good to give it. Now we give our, not after the clamping of the cord, but we give it with the induction of anesthesia. We give second generation cephalosporins, we give cefazolin 1 gram. And for cesareans, we give Reflin, that is cefazolin, okay? But please remember, the prophylactic antibiotics are only for the planned, clean and easy case. If it is a difficult case, lot of blood loss, prolonged labor, go for therapeutic 5-day course of antibiotics. Subcutaneous tissue, if the depth of the subcutaneous tissue is more than 2 centimeters, it is good to take a subcutaneous layer. Otherwise, normally we don't take them. And skin, we normally put subcuticular stitches, but if she is a diabetic, obese and it's an infected case, we go by the interrupted skin. Thank you.